really pleasure to be with you here. I've been in England for the last 25 years and decided to come back to Egypt, which is, I think, is the most courageous decision I took in my life. In my time here, 2 months, I saw 3 vaginismus cases. I'm not quite sure if you see some vaginismus cases or not. Hands up who's seeing vaginismus cases in his practice. And what you're doing for them. Anyone to say what you're doing for them?
I'm Dr. Ekta from UK.
Yes.
I'm a fixed therapist. I'm like speech therapy and medical science. So I do the
Excellent, doctor. Thank you. What is sexuality? To understand what's vaginismus, we need to understand what is sexuality. Sexuality is the thoughts, feeling for others, male or female, experience attraction, and then being in love. After being in love, then the sensuality will come, or the physical contact can come. So sexuality is not only intercourse. Sexuality has so many parameters and factors. Can be biological, physiological, psychological, anatomical, and in countries like us, cultural. We have our lovely limits and gates and prohibition in our culture. Egypt nowadays is not the same Egypt I know 25 years. And all the countries are not the same. Internet opened everything for us. And everyone now coming to say, I want this or that. And sexuality is not different. I want you to concentrate on 2 things, the green one and the blue one. The intimacy is a feeling of love, the romancia. And sexualization is the act, the physical act. And we need to understand the circle of sexuality to go to where the couple come with difficulties. Before talking about vaginismus, I need to talk about a broad spectrum issue, which is called female sexual pain. It is not only vaginismus. Female sexual pain can be anything. You remember the differential diagnosis when we were medical students? You know, the infection, malignancy, whatever you can say, all is there. All is there. This is very sensitive area for everyone. And if it's not sensitive for the woman, as well sensitive to the man, he needs a healthy woman. So female sexual pain can be disorders, can be syndrome, can be anything, and it contains as well in it vaginismus. The big picture is the female sexual pain. And it can include all what I said, and this is detailed in this slide. And it can crack life. It can crack marriage, like very weak egg. It gives negative impact on confidence, self-esteem. Both sides, by the way, is not only the woman. The unconfident woman will either be treated by unconfident man who's abused her or overconfident who undermining her. And it can affect the relationship, quality of life. And it's difficult to define what is the pain, the cause for the pain. And it's always, as we all know, it's multifactorial or multi-dimensional. And the question is, how is the joy which Allah created to create the human nature and the new generation, how that joy can hurt? Again, with the female sexual pain, function as well. It is a challenge. In the beginning, when I say to you, vaginismus, you see, yes, but no one, I am one of you, who go deep inside to take what is the problem. Because that can be challenging, vary with culture and age, and as well, immeasurable. We cannot measure that pain. There is no scale for it. And the reported incidence for female sexual pain varied, as we said, and it's very obvious in the incidence as well, 6 to 40%. I would be very interested about the incidence in Egypt. If anyone have any incidents, please let me know, so I can add it to my lecture and say, yes, in my own country, this is what we have. Now we're coming to the heart of my lecture. Vaginismus. What is vaginismus? Definition in Arabic is التشنج المهبلي. And I don't know what this means. Is it تشنج البدي or تشنج المهبلي? And from that تشنج المهبلي come to be the definition of Oxford Dictionary. The Oxford Dictionary in English, painful spasmodic contraction of vagina in response to physical contact or pressure, especially during sexual intercourse. It didn't say here that is only sexual intercourse. It said even if the patient breasts herself, putting tampon or vaginal examination. But the old one in 19th century, it is recurrent or resistant involuntary spasm of the musculature of the outer third of the vagina. I don't know how they diagnose the outer third specifically. Very precise anatomy, isn't it? And I'm sure one of you will answer me, why the lower third? That interfere with sexual intercourse. Our definition in Arabic is still on the recurrent, resistant, involuntary contractions. It didn't follow the Oxford one. And why the lower third? Anybody knows? I will try to say. The two upper thirds of the vagina is embryologically different than the lower one. Genital tubercle is the lower one, and this is full of innervation. The main nerve ending in the vagina is G-spot, 8,000 to 12,000 nerve ending from cadaver studies, and the vestibule. So touch the vestibule in a vaginismus patient, and she will kill you if she is grade 4 or 5. This is the definition. If you agree with me, I will be very happy. If you not, please tell me what's different. The prevalence and incidence of vaginismus, as you know, is not always a case of complaint. It's known in Turkey, 1 in 10 ladies, and out of these patients, 73% of these patients actually request 6 therapy clinic consultation. And it's estimate, and it's showing the variation as well, 1 to 69% in the Western countries. So studies can say to you 4%, other study can say 69%. Nobody knows, because the cohort of patients vary with age, with birth, with culture, with so many factors. That's why we cannot have one parameter and measurement. Types of vaginismus. What we know all, it is primary or secondary. What I mean by secondary is a patient who delivered and come after birth trauma, and she's sleeping in the baby's room for a year, or 2, or 3. And this is because she had a scar, she had pain, and she cannot stay. or patient who had radiotherapy and the vagina is all tight and you cannot put anything in it. Most of them, the vaginismus types, are 70% primary. The cases which will come to us is the primary one and the most difficult one. The rest all is treatable. And even with the 70%, 90% of them is treatable. So vaginismus is not a nightmare. It is a treatable condition. Global and situational, that means nobody can touch her. Situational, it depends on the partner, circumstances, بيت العيلة, أجازة, different. Spasmodic or non-spasmodic, again, the patient can feel that and tell you. So it's not measurable. Why? Why vaginismus is happening? From my previous colleagues, which I thank them all for their presentations, you can have a lot to say why. We all know it is multifactorial, physical, psychological, whatever it is. In Turkey, a study of 200 women with vaginismus showed the fear is the most important one. 60% they fear from it. They live all their life in the fear from the first night. And 18% because they have forcible partner who's abusing the first intercourse. And 10% have sexual abuse at childhood. The interesting for me is the negative thoughts of sexuality, bringing me to the community, to the limits, to the barriers we have in our upbringing. I am not advocating here sexual education in young age, but I want everybody to be aware about what's normal, what's not normal, within the context and frame of the legalized and moral values of the country. 2.5%, that is very unusual. Witnessing their parents during the act. Obviously that little bit, not the best, but it happened. And 1.5 vagina. This slide is only saying to me, it's a fear. It is, I'm afraid, I can't. They told me. And this is what the woman said. I know well that the woman never lied. Isn't it? All women say yes? Never lie. So this is all you can actually read through it. Interesting one is the last one. One of them said, I'm afraid if my vaginal muscle clamp down, how he can get out. I think I heard that 25 years ago in Zagreb University. One lady came and said that to me. And interesting because it's coming even in literature. ليلة الدخلة, taboo of the first night. Are we all still afraid of it? Obviously, الأفلام والmedia giving us a horrible nightmares. But this night specifically still taboo in our society. It has a great importance. Everyone is waiting outside, and the mandil need to come with a little bit of drops, whatever. And sometimes the husband cut his finger and put blood to go out and put to elected. Because this is pressure. But let us not forget, both couple didn't have any, most of them, if I can say, didn't have any experience before. And for both of them, it's experimental. And they are allowed to try and error. But how long? As we said, vaginismus is not measurable. But when you have a patient coming to you, and she say, I never touch myself, doctor, you cannot put your finger in me, I'm sorry, or whatever, then you raise that awareness and say, yes, sit down, we need to talk. We need to take first a very, very detailed history. Medical, psychological, and sexual. In every single detail. And you need to see both of them together. Vaginismus cannot treat it ever by a woman alone. Because it might be him had the problem. We need to see both of them, listen to both of them separately and together. If you feel that the story is not matched, then take everyone separately and talk to them. The session for vaginismus patient between 1 hour to 1.5 hours. How we diagnose it? Is it by history only? Well, Lamont gave us 5 grades. And Basic gave us the 5th one. The first one is normal. Most of the ladies in our culture can come and say, no, please don't examine me. But with reassurance, she will be examined. The other one, I'm able to relax, but examined. So the entrance is there. The 3rd grade for Lamont classification is the buttocks up. So I'm ready. I'm going to kill. And grade 4 is the generalized paralysis. Or she will be spastic. The last one is the most important one, where the patient can have a shock with you. She will be sweating, almost fainting, and she can't do it at all. She cold all in the body. I literally, intentionally, I didn't put any pictures in that, because the pictures is hurting me when I put it. Treatment. As we know, vaginismus is not the only sexual dysfunction which can be treated completely. The treatment should be authentic and reflect the couple's and society views and tradition. Treatment here is different than treatment in UK. Should be individually tailored. You should be empathetic and understanding what the patient is telling you, or the couple, not the patient only. And we need appropriate space and time, which we cannot have actually here. My last patient, I borrowed a clinic from a very close friend to me, and I stayed with her 1 hour and 10 minutes, both of them. And I don't think we can afford that. The first thing is to establish consent. Patient must agree that this is where we are going to head, and purpose of examination. If she wanted support person, bring with her someone. If she doesn't want the husband at the moment, first meeting, see her alone. If she wanted anything else, allow, like music, video player. And one of the best things is to teach the patient, educate her about herself. Because some patients never see themselves in the mirror. So hand mirror is the second tool. Let the patient sit on the couch and tell her, this is called so and so. This is called so and so. Allah created us in this area because of that. And the patient reflecting on that mirror to see that she's normal. Because some of them thinking that they didn't have any opening. Sometimes you can give an anxiolytic, if you will. You can have the therapist with you. You can prepare the patient mind-body program, sort of like some videos to see, and cognitive behavioral program. This is in all in a brief. After that, you establish the rapport between you and your couple. I'm still insisting on this couple. Without the help of the husband, this patient will not be cured. their marriage will not consume, their happiness will not come. While the support person is there, husband is there, therapist is there, you still are the boss. We move into vaginal examination, or genital examination, because we are not going to the vagina directly, we're going to genital examination. So the word is intentionally genital, not vaginal. Because if you go vaginal, you humiliate this lady. She's coming because she can't be introduced, and you're just entering. No way. So vaginal inspection, sometimes, is not always the case. We use colposcopy to magnify. Then while you are examining, you explain to the patient the anatomy. Harder. But this is the most important thing, is the pressure point testing. Pressure point testing, everywhere you are, you need to know which point the patient is in pain. And start outer to inner. And then with the vulvar vestibule clockwise. And have like a swab, put on one, and touch. It's not deep. You're not poking her, just swab. And then after that, let her, with her finger, repeat what you've done. So she needs to tell you in the mirror, what this? Where is this area? Introduce her to herself. This is the mind-body fullness. Desensitization is exactly like desensitization. You try to go inside the vagina by any means, so that her fear of penetration by any means is voided. And the circle of fear and anxiety and avoidance will be stopped. You can use the husband for that as well, but it needs to be later on, at least after 3 sessions. The steps we need to take is sex education. Sex education is not like pornography or anything like that. Sex education, she's a married woman, and you need to tell her what the normal, because her mom didn't tell. Her auntie told her different stories, and she heard from her friend horrible story about the bleeding in the night. Sex education, self-exploration and sexual anatomy, very, very important. Sexual physiology and behavior. Muscle control. Patient need to know how and when to relax, and how and when to contract. The outer 1/3 of the vagina, pubocoxagus muscle, she need to feel that on her finger. She need that tightening on it, and ask her to relax, and then contract, and so on and so forth. You and her alone, and then you can use her finger, and then her husband's finger, and then after that, leave them alone. Sensate focus is the most important thing we can do. This is started by Master and Jones in 1970. They were very interested in why patients had difficulties, and it is the art and act of touching and being touched. So step 1, start with non-genital touching, then genital touching, then adding lotion so it's easier and more enjoyable. And then manual, mutual touching, both of them touch each other, and then sensual intercourse. The word sensual is not sexual. Sensual is I need you, you need me. And then things can come after that. Behavior insertion exercise, 89% is successful. And usually, it's either in vivo insertion or in vitro insertion. In vivo is the patient herself can put her finger or dilate. In vitro is the therapist, husband, or doctor can do that for her. And depend mainly on the patient, because the minute she will start to put the tip of her finger inside the vagina, she's already started the treatment. This is a study done between 10 of each specialty, 10 gynecologists, and 10... okay. who's a patient who had cancer, vaginal cancer, and had radiotherapy. And they recommending that she started dilators 4 to 6 weeks for after the treatment, and then to continue for at least 3 months. And this is a case I can tell you in the break. And what not to do is the common thing here, hymenectomy. Don't do that. And don't leave the patient for herself, because this is not fair. And pelvic exercise alone will not help. And I am leaving the Botox for my respectable colleague to talk about it. And the results, as you can see, the cognitive behavior therapy, which is Master and Jones, which is its steps of touching, is 72 to 100% success. The other one is 89% success. My own view from my own practice, I have psychosexual diploma. Intercourse is a physiological event and feeling. Allowed. Don't prohibit it, please. Vaginismus can be treated completely when multidisciplinary team and appropriate setting are in place. Teamwork between therapist and the couple is a success key. And this is to take home that vaginismus is underestimated and underreported totally, and we need guidelines, protocols, and training for all of it, part of it as well. And for all of you, we all know that medicine is a science of uncertainty. But we need to act on the high probability. Thank you. This is St. Mary's Hospital.